So welcome everyone. I am so honored to welcome you today to this webinar that is being hosted by the Families SCN2A Foundation and the International SCN8A Alliance. We're really excited to be doing this in partnership, and I have to thank Leah for always being open and willing to find ways of working together. And I think you'll hear today, especially from Erica, about why this is probably a really smart populations to pull together, because there's a lot that I think our communities have in common, and it's going to be powerful for us to have these conversations together. So today we'll be talking about challenging behaviors in SCN2A and SCN8A, and we have a really exciting lineup, a variety of voices, both from the SCN2A and SCN8A family perspectives, and then experts who are going to be sharing both some background on the communities when it comes to behavior, in part based on the survey that many of you filled out. Thank you so much for doing that. It's really incredibly valuable information. And I know that there will also be some data from the SCN2A clinical trial readiness study, which it's amazing what your community has built there, and that really valuable data. So congratulations to that team on pulling that together. So, this is a webinar setting, so only the panelists are on camera and will be heard. So if you're in the background doing laundry, caring for kids, don't worry, we can't hear you, we can't see you. Just listen in and take note. Feel free to please use the chat actively throughout. If things are resonating with you, you say it's the same for us. I hear you. It's a place where you can connect and chat with each other. And also feel free to, throw your questions into the Q&A or in the chat, because we will be saving a good chunk of time at the end to really discuss and take questions from you all. The format for today is that we're going to open with a story from Mary, who is mom to Billy, who has SCN8A. Then we're going to hear from from Carly, who's going to do a bit of an opening. Then, I'm sorry, I did it backwards. Carly, and then Mary. And then Erica is going to share some background on the 2A and 8A communities based on that data. Then we're going to hear from Jennifer about Jack's story. And then Kelly, really excitingly, is going to analyze that, going to help us think through what are strategies that you might implement based on what you heard. And I think you guys can also be throwing things in the chat there as you're listening and hearing. And then Chris is going to share Maddie's story. And then Carly and Dr. Tate are going to jump in and do the same thing, which is really exciting to get real-time feedback and analysis and give you guys ideas about how to take this and bring it to your providers and say, let's talk about this. I want to learn more about this. And then we'll have plenty of time for Q&A. So that's the structure for today. I'm going to start just by handing it over to Carly. She's going to introduce herself to you. And I'm really grateful to all of these panelists for joining us today and sharing. Thank you so much.
Thanks, Gabi. My name is Carly Vanderhyde, and I'm doing my psychiatry training at the University of Iowa. I am here today because I have a special interest in working with people with challenging behavior, because of its impact on the quality of life, and because the lack of resources and expertise in this area is big. Here at the University of Iowa, we have a specialized psychiatry clinic for adults with intellectual disability, where I work as part of an interdisciplinary team whose goal is to identify and treat the underlying causes of challenging behavior. My clinical mentor, Dr. Jody Tate, is here today also to participate in the discussion later on, and has many years of experience in this work. We haven't directly cared for anyone with an SCN2A or SCN8A diagnosis that we know of, but many of our patients have autism, epilepsy, and complex medical needs. I knew nothing about SCN2A until I heard Dr. Ashleen Williams, who's also attending today, give a seminar on her lab's research studying premature stop mutations in SCN2A. And after hearing her seminar, I promptly joined her lab. She brought me to the Families SCN2A meeting, the annual meeting last year. And I was just amazed by the community of families, clinicians, and researchers working closely together to learn and brainstorm about how to take steps towards treatment and improving quality of life. I tell people about that conference all the time. I'm really excited today that I'm now also meeting the SCN8A community. I'm looking forward to sharing what I've learned so far about challenging behavior and learning from all of you. During my portion of today's presentation, I'll emphasize how the underlying causes of challenging behavior are complex and multifactorial and need to be addressed collaboratively, not only between different clinical specialists, but closely between providers and patients and their families. One of the things that I love about my clinical work is that I'm constantly learning directly from patients and their families because there's no textbook for this. In fact, in preparation for this webinar, I met with Chris, who you'll hear from later, about her daughter Maddie, who has an SCN2A diagnosis. And after our conversation, Chris sent me a link to a webinar about autonomic dysfunction by Dr. Keith Kaufman, pediatric neurologist. During the webinar, he showed videos of kids having these autonomic episodes, and what I was seeing was remarkably similar to what I've seen in videos of one of my newest patients who has autism and self-injury and doesn't have a genetic diagnosis. And he sought care from 5 different neurologists, was told it wasn't seizures, but didn't know what it was. So I sent his family the link to the webinar, and now we have some ideas for next steps. So who knows how many others that webinar made a difference for, and this is all to say that events like this truly make an important impact that reaches infinitely beyond just the folks who are here tuning in today. So I'm very happy to be here to discuss this important topic with all of you. There isn't a lot of clinical guidance out there on how to evaluate challenging behavior, and that's largely because it's a topic that is rarely, if at all, discussed in medical education. Many clinicians just don't know what to do. And this puts caregivers in the position of trying to figure it out and fix it on their own. And when challenging behavior continues or gets worse, it can feel like failure. One of the messages I hope to convey today is that the approach to challenging behavior should never be a one-person job. And the reason it often comes to that is because of failures in our healthcare system, which I'll speak more on later. There's such an unmet need, which is why it's so important that we're here today. So thank everybody for being here. And thanks to Leah, Sean, Gabi, Erica, and Kelly for putting all the pieces together to make it happen. So now I'm turning it over to Mary, I believe.
Hi, am I on?
It's all you, Mary. Thanks for joining
Okay.
us.
Hi, I'm Mary from Syracuse, New York. I am mom to Billy, who has SCN8A, a rare genetic epilepsy. He has had absence seizures, which were first recognized around age 3, and was diagnosed with SCN8A at age 17. Additional diagnosis, he has ADHD, anxiety, intellectual disability, autistic tendencies, scoliosis, osteoporosis, and these are all comorbidities of his disease. Billy's 22 years old now, and he lives at home with us, my husband and I, and his older brother, and he's going to live here with us always. He's able to talk, walk, and move independently and is independent within the house, however, needs one-to-one assistance for bathing, toileting, dressing, and shaving. He must always have somebody with him when out of the house for safety reasons. He loves people, airplanes, car rides, and watching the news. He is generally happy and engaging with a very strong, loving, and empathetic personality. In general, most days are really good ones, but some are not so much. Billy's triggers, we tend to see that fatigue or not eating regularly every 3 hours, anxiety, changing routine or plans, or just general frustration can cause an episode. Some of it was from medicine side effects. Sometimes I think it's the full moon. Sometimes we just don't know what Billy's trigger is. I know if you're on this call, you're experiencing and worrying about behaviors. Through the years, we've experienced behaviors from Billy ranging from hitting, throwing things, biting, pinching, and self-harm, such as picking his skin, nails, and pulling out his eyelashes. I know some of you are dealing with far worse and some not so bad. Some of you are thinking, man, I wish I was only dealing with a kid pulling their eyelashes out. But no matter the degree or the intensity or the duration, tough behaviors are just that. They're tough for all of us. Nobody has it any better or any worse. It's not a competition any of us want to be in. This is not what you expected. You expected floor seats to your favorite concert, and you find out that you're in the third tier and you're afraid of heights and there's no handrails. That's your life now. But you know what? The third tier can be great and it can be fun and it's not crowded. And your view is from a different perspective, and that view can be beautiful. Here's what I've learned in 22 years of loving Billy. It may not get any easier, but you are going to get better at handling it. Experience matters. The things that used to bother me no longer do. I've learned to realize what matters, what's important, and what I'm willing to give up, and who is important. An example of this is I try to make Billy's life fun. And I remember one Christmas season, I booked a lot of fun things to do, plays, concerts, whatever. But you know what? It was too much. It was too much for Billy, and I should have known better. In an effort to make his life all that it could be, I neglected to think about what was best for him. He fatigues easily and has a rigid bedtime of 7:30 p.m., which he insists upon. I know I'm taking a gamble if I try to attend anything in the evening. I always try to book a matinee or plan things during the day, or else we just don't go. But some things you can't arrange. And in that case, I try to enforce a nap or a rest time and hope for the best, and hope that if he's well rested and he's eaten, that I can avoid some potential behaviors. One of those wonderful, expensive Christmas events I had booked, front row seats for real for a concert. I got up and left before it even started. Front row of an auditorium locally. He's hitting me. He's pulling at my clothes. You can see my bra. And I knew there must be people there that knew us. I worked in a school at that time and I was mortified, furious. I yelled at him all the way home. It took a while to calm down. But when I did, I realized this was my fault. He was tired. It was late and he didn't want to be there. I wanted to be there. I wanted him to experience it, but I really didn't realize it didn't matter to him. His expectations and mine were not the same. My real aha moment came in the parking lot of a local theater company on a beautiful summer day, afternoon performance, everything in order. He ate, he went to the bathroom 800 times. It was perfect. What could go wrong? Well, Billy refused to get out of the car to go in. Why? I don't know. I still don't know. It was a perfect, fun musical. It was Grease. He would have loved it if we had gotten in there, but we never got in there. He was freaking out in the car, in the parking lot, and every old person in 100-mile radius was getting off a bus and giving us the stink eye because my kid is freaking out and screaming because I'm taking him to a play. I was embarrassed, I was angry, and I was mad about the money that I lost. But you know what I did? I drove away. And that was it. And that was my aha moment. Immediate calm came over the car, and I realized we just need to move on. It's not going to happen today. And that's okay. Now I know that I need to ask him if he wants to attend something. And if he says no, then it's no. Usually I'm the one that's disappointed, but it's not worth the stress to both of us. If we do have plans to go somewhere, I prep him as much as possible. And he knows this is a choice we both made, and it's a have to. Honestly, our quality of life has been impacted by Billy's diagnosis. It's not worse, it's just different. You're in the third tier, right? You're here for the music. So does it really matter where you're sitting? Some things we choose not to attend anymore, like family gatherings, where people often are sick, judgmental, or just not that pleasant to be with. Choose not to go. It's okay. Be flexible. Plans have to be fluid. If the behaviors start, don't box yourself into something that you're going to regret. Have an escape plan all the time. It's okay to get up and leave if behaviors are reaching their ugly point. Don't judge yourself. And if other people are judging you, who cares? A place I often got up and left often and no longer really go to, and I miss, church. Boy, old people are mean and they can be really judgy. And if I ended up all stressed, sitting there worrying about my child's behavior and people judging me, it's not the place that church needs to be for me. It might be anything for you. It could be a ball game. Don't be afraid to give things up that cause you stress. Don't make threats if you're not willing to follow up on them. I've done this and man, I regret it. Don't punish yourself when behaviors are bad, such as, if you don't stop right now, we're not going to the fair. Well, if you really wanted to go to the fair, don't use that as a threat and take it away, because you're just punishing yourself. Pick something you don't care about. Just remember, it's not your fault. And don't use things as a punishment that you may not want to give up. This next one is taken from a site I found on Facebook that I really like. They have it's a family with an autistic son called Bacon and Juice Boxes. Age appropriate is relative. And I have really learned this with Billy. He's 22, he's 6 foot, he's 200 pounds. And without fail, he is the biggest elf every year on the Christmas tree. Picture Buddy the elf. Tiny little kids at the tree and Santa, and there's my elf. I wouldn't miss it for the world. Front row of Paw Patrol, yes, sign me up for that. No third tier for Paw Patrol, Disney shows, any of it. I'm really sorry if your 3-year-old can't see over my son's head, but too bad, because he loves it. And along those lines, know that third tier is only a reference point. In actuality, if I can't get tickets to something really up close, I typically don't go, because I know it won't hold his attention like a play. So I have to think about what's good for him and what he can gain from something and appreciate. And if I feel like he's not going to get the experience I want, I just skip it. It's normal and it's okay to be disappointed, angry, hurt, and embarrassed, but only briefly. Don't stay there. Don't wallow in it. Move on. Don't miss the gifts that life has given to you in the form of your child. And don't be afraid to ask for help. Counseling, respite, taking time for yourself. This is tough on marriages and siblings and families. Seek counsel from other special needs families. Strong point of support. Doctors, therapists, they are your key people you need to go to. I'm going to say choose very wisely what you share with the school. Really think about who you trust. A lot of that you might want to keep within your family. I reached a point early in Billy's life where I felt that I needed something to take the edge off, because I found myself yelling at Bill a lot for things that were beyond his control. These kids can't control this stuff oftentimes. I was screaming at him in the morning to hurry and go to the bathroom because the bus was coming. He's constipated from seizure medications, not his fault. I realized I need to calm down my response to Billy so that he in turn is calm. Sometimes I'm feeding into the behaviors. So I found that at that point, a little citalopram was something that took the edge off for me, and it allowed me to better handle what was going on with him. That's my personal choice. Everybody needs to do what's best for them. Recently, Billy's acts of aggression have become more frequent or intense. Again, 6 foot, 200 pounds of angry bear is not easily managed. Hitting, hair pulling, kicking, punching, throwing things, very physical, and incidents lasting up to an hour. It often takes 2 or 3 of us to restrain him, and even then it's a full-on battle. As my husband and I age and Billy gets older, we realize it's time to do more to handle his anxiety. We met very recently with his doctor and decided to have him take Lexapro daily. And we have an emergency med of hydroxyzine, I'm probably saying it wrong, as an emergency medicine if we notice him starting to build up. And we do visually see when he's starting to have an incident. We've been on it about 2 months, and I have to say I've used the emergency med 3 times, and he's on Lexapro every day, 5 milligrams, and I'm happy with the results. I think it's allowing him to be easier to scale himself down during an incident before it goes full blown. We've resisted medication 3 years. Lots of resistance to any type of anxiety medication. Wanted nothing to do with it. But honestly, we probably should have done it sooner. It is making things better for Billy. It's taken me, excuse me, it's taken me 22 years to reach this point. So don't reinvent the wheel. Do what's best for you and your family. Don't compare yourself to other families. Life is different for sure. Please don't focus on what they can't do, but the benefits of what experience they bring to your family. Billy won't ever drive, but I never have to teach him to drive either. That's a plus. No speeding tickets. The insurance won't go up. He's not going to take advanced AP courses or the SAT. I don't have to anxiously wait for the test results of a test he never has to take. There's always a plus side to everything that we feel should be happening. Plus, all these things, sports and everything, you save a ton of money. Put it towards a family adventure. If Santa's magical in your 22-year-old's life, that's a gift. The magic of Christmas forever. Choose wisely. Can you handle Elf on the Shelf for 50 years? That's a lot to take on. I have realized that now. Is life what we expected it to be? No, it's not. It doesn't meet expectations for a lot of families, though. They might have kids with drug issues, alcohol issues. They turn out to be in a profession you're not really a fan of. It can happen to anybody. We should be empty nesters by now with a great deal more freedom. My husband and I are both retired, but Billy can't be left alone ever. And one of us oftentimes opts out of events. We've missed a lot: weddings, funerals, family events. And I'm sure people don't understand. They don't care. But honestly, I just don't care anymore about what they think because it's not important to me. We've come to terms with it. We'll never be empty nesters. And someday we pray Billy's siblings will also not be empty nesters when they take care of him when we're gone. Learn to enjoy the simple things that they enjoy. Treasure those good days. We like to buy lunch and go to the airport and watch the planes, or go for a ride, or spend a little extra money in a hotel that would be fun for them. There's so many enjoyable, peaceful things that we get to do with them that counter the days that are a little rough. The bad days can be bad, but the good days are so good. And you can still hear the music from the third tier, sometimes even better. That's it.
You're gonna make me cry. That was incredible. You're getting a lot of rave reviews in the chat. I see everybody sending love. Incredible. Thank you so much for sharing your beautiful and challenging reality with Billy, who we all know is a superstar. So I'm grateful to
Thank
you,
you for
Mary, for being
asking.
with us. Yeah. All right, I'm going to go ahead and hand it right over to Erica, who's going to go through some of the data that you all shared.
Hard act to follow with data. I don't know. I think that I would stick with Mary for a while longer. Mary, that was lovely. And I wish I had known you when I had 3 young children under the age of 4. Just all that advice was, I mean, my kids didn't have SCN2A or SCN8A, but everything you said resonated with me in terms of what I was going through when I had 3 young children at that age, and loved it. Thank you. It was beautiful. Yeah. So I am Erica Anderson. I'm a clinical child psychologist. I'm new to the fairly new to the SCN2A community, and very new to the SCN8A community. Sorry, I'm gonna be mixing those up a lot, so just forgive me. I started with the working with Ann Berg in the clinical trials readiness study for SCN2A a couple of years ago, and just I was like, I don't know what I'm getting into. I don't know anything about this. My job in the study was to train our research assistants in doing the Vineland comprehensive interview and engaging with families. And in the course of that study, I was just so, I became so mesmerized, so in awe of the families. I learned so much. And I learned so much actually for the work I do, which is really that I am very familiar with, is that I'm not new to, is challenging behavior with young children. I've been doing early childhood mental health consultation for over 35 years. And of course, one of the main referrals is for challenging behavior. That's what teachers struggle with. That's what parents struggle with. When I started with this, parents didn't know where to go. They would have they would have a 2-year-old who's, scratching themselves or head banging or having these tantrums that would last for hours. And they would tell their pediatrician, my child's having tantrums, and they would hear, oh, that's normal. All 2-year-olds have tantrums. He'll be fine, he'll grow out of it. And they're like, I know children have tantrums, but not like this. This is something different. This feels different. This is impacting the quality of our lives. I feel like a terrible parent. I don't know what to do. Luckily, in the early childhood community, we're getting a little better at addressing those behaviors. We're not there yet, but we are starting to understand that there is a difference between typical tantrums that most children have, and challenging behaviors when a child is hurting themselves, hurting others, or hurting property when they're so distressed they just don't know what else to do with themselves. So that, and then my other focus has been on research at Northwestern University around making that distinction between what is typical, or what is we call normative, temper loss, irritability, and when is it a cause for concern. When we really need to take a closer look, so we don't have pediatricians saying, "Oh, don't worry about it," or other parents saying, "Oh, it's fine. You just need to, be firmer," or "You just need to ignore the," just getting all sorts of advice that's not very helpful. So that's where I'm coming from, and I'm going to share a PowerPoint so I can show you some of the data. Thank you all so much for filling out this survey. I went through that very carefully. All right, can you all see my screen? Is that good? Good, okay. I'm sharing it correct. If somebody chats me a question, I won't know it. And so if there's anything to just maybe Gavi, let me know if there's any questions that I should stop. Because I cannot multitask at all. So I can't
No
look at
worries.
questions.
If they're relevant to what you're talking about at that moment, I'll interrupt you. Otherwise
we'll
maybe
wait to the
save
end.
questions. Yeah.
I just wanted to note that because I am not good at multitasking, so I just cannot focus. All right. So completing the survey, we had the SCN2A and the SCN8A community. We had fairly close numbers. We had about 20, I think it was about 27, 20, I'm not sure the exact numbers. I think it's a little higher now. I think this came in at about 27 with 2A and about 33 or so with 8A. So good numbers. Thank you so much, everyone, for filling that survey out. Most folks had been in the SCN2A or 8A communities for 3 years or longer. This is just a little. Now I'm separating some of this out from 8A and 2A. When there's some difference. I don't know if the differences are significant. We didn't do analysis on this. It's just by eyeballing. But these are the behaviors that folks reported that we specifically ask about. So when we're talking about challenging behaviors, and specifically for this webinar, I know there's a lot of different kinds of challenging behaviors, right? There's other things that we weren't asking about, but we were asking really about sort of behaviors that are about like temper loss and irritability and anger, right? So kids who when they're so distressed, they injure themselves. They might have injurious behavior towards others, hitting, kicking, biting others, or property destruction, tearing things apart, breaking toys, and then just general tantrums, crying, screaming, whining. And so most kids have tantrums. And in my work with young children, almost all young children have tantrums at some point. But this is for the 8A. Here, I'm going to go to the next slide because I think it's a little easier to see. About 67% of the respondents reported that they have some self-injury with their child experiences, which I think is a significant amount. All right, we're a self-selected group, right? People are coming here because they're really to this webinar, because they want some answers to the challenging behavior. But so I'm going to put this in a broader perspective in a moment. But of the respondents of the survey, we have about 67% saying their kid is involved, having some self-injury. And then there's some, about 60%, similar amounts for injurious behavior towards others, property damage, and then most of them have tantrums from time to time, right? That's pretty typical. In the 2A community, you see that there's a lot higher, and I don't know if this is significant. It could just be the people that responded to this survey, but just something to kind of just in terms of who's on the call, a higher percentage of folks reported the self-injurious behavior, but also injurious behavior towards others and property destruction, as well as tantrums. So we've got about 81% saying self-injurious behavior. And then in terms of frequency, how frequent? In the 8A community, multiple times a day. Oh, and I just want to say that these are overlapping categories. You could have a child who has all 4 or only has 1. So that's why it doesn't add up to, this adds up to only 27 people responded, but it adds up to a total of 62 because about some of, I didn't look very carefully, but I know about a quarter of them reported all 4 behaviors at once. And then some just reported, usually typically there was at least 2 of these behaviors. Rarely were they only, kind of having to deal with one of them. So that's why I just wanted to point that out. And then frequency, we have the multiple times a day. So this is, any of those behaviors may be happening multiple times a day, daily, weekly, monthly. Here, I'll kind of show you in statistics. So about 30% are happening multiple times a day. And that's, you can imagine, right? How challenging that is if you're going through your day, and it's not just when you have to bring your child home from the park, they're going to have, there's multiple things that might kind of trigger this. Slightly higher in the 2A responses in terms of multiple times a day. They were saying about 51% were saying multiple times a day. And again, I don't know what that means. We don't know in terms of, is that really a true reflection of the 2A community versus the 8A? But it's just what we're seeing, what we have here in our webinar today. And putting this a bit in perspective, I'm going to go back to the types of behavior in the 2A. Here, let me go back to 2A. Sorry. There we go. Challenging behavior in the 2A. So in our larger study, in the clinical trial, in the larger study, the clinical, readiness trial, trials readiness study. There we go. About 40% of the respondents reported self-injurious behavior. So of course we have a little bit of a self-selected audience here. Typically in young children, and I know this is a full age, these are not just young children, these are children of all age ranges. But when we look at young children who, 2-year-olds, 3-year-olds, 4-year-olds, so kind of the preschool age behavior, we see this in about 20% of children, depending on kind of what study you look to. But and it typically is a red flag. We use it as a screen. I use it as a screening question. If a child is, if a teacher or a parent is reporting, tantrums and temper loss and difficulty with distress, one of the things I ask about, are they hurting themselves during these episodes? And if they are, it typically means it's beyond just what's kind of a typical of a young child, right? It means there's something else going on for them, that it's not just sort of the normative learning how to regulate their temper, their big feelings, their behavior. They're really struggling with something that they're needing probably a little more help with. Then they're just gonna, it's not something they're just gonna necessarily grow out of. They're gonna need some more support. And the same thing for the injury, the hurting others when distressed is around 20% as well as property destructions. All of these are about 20% or less in kind of a population that does not have a diagnosis of SCN2A or 8A or significant intellectual or developmental disabilities or epilepsy. So you can see here where, it's a little, especially even in the clinical trials readiness study, the self-injury is about 40% of reporting at least sometimes they hurt themselves. Injurious behavior towards others was closer to about 36%, and damage to property was about 33%. So a little bit higher than what we'd expect. And which means that, and my, behavior is a means of communication, right? It's letting us know what's going on for the child who may not always be able to communicate. And in my work with young children, we have to be detectives, because they can't let me know, oh, I'm constipated and so I'm in pain and that's why I'm having a fit, right? They can't, preschoolers can start doing that. 2-year-olds, 18-month-olds, 1-year-olds cannot. So I use their behavior. I try to really understand what's going on for them. Their behavior for me is a form of communication. It's not a, I don't look at it as a problem to be fixed, but as a way of communicating what they're needing so that we know how to help them get their needs met, so they no longer have to have that behavior in order to let us know what they need. And I'm going to move on to, we did that already, sorry. Why? So what are the triggers? We could say triggers, we can say what contributes to the challenging behavior. This is for all information from your survey, and it is exactly what I experience in my work with young children. This exact same triggers, exact same contributors are at force here. So we have things like, of course, frustration and anger. I should have printed this bigger now that I'm looking at it, but that's okay. You know, that's sort of the common, that's what we often think about when you're feeling frustrated, you're feeling angry, that's when you sort of lose it, right? But that's just one. And that's often what we always just think. We always go to, oh, if they're frustrated, they're angry. But sometimes that's not it. That's only one possible trigger. There's communication challenges, right? Which leads to frustration and anger. But, you know, but expressive language delays, processing disorders, I see that a lot. Sleep disruption, disorders, disturbances, deprivation. That's a big one. That's one that often is such a it's not a causal. It's not like I didn't get a good night's sleep, so therefore I'm going to lose my temper. But it's contributing. I didn't get a good night's sleep, therefore I'm more likely to lose my temper when someone cuts me off when I'm driving, right? So it does increase the chances in a typically developing population of kids without like seizure disorders. So I'm not quite sure how that kind of translates when you're also just having seizures during sleep or there's other issues going on, but it does contribute to temper loss. Hunger. These are all things that people reported, yes. And sometimes we don't understand, they just ate. Well, you know, some kids have different metabolisms. They need different amount of food. People said pain, illness, that's a big one. And they can't always express themselves, right? In terms of what hurts. I see this a lot with kids with undiagnosed ear infections. Constipation is a big one. It's very painful, right? Mary mentioned that, right? You yell at your kid and they're trying to go to the bathroom, you can't get out the door, but they're in pain, right? It hurts. Sensory sensitivities. So kids might be easily overstimulated, understimulated, noises, lights, things that we might not even imagine they're feeling sensitive to, feeling of their clothing on their skin, feeling crowded. I discovered that this is my big thing, which I didn't know, you know, I was like 50 before I realized how overstimulated I get in malls and how irritable it makes me. And I stopped going to malls because it's like, I would like be so irritable and it's like, okay, figure that out finally, right? Demands, limits, expectations, right? So, you know, which we always have to place demands, limits, expectations on our children, so that can be hard. Transitions, disruptions in routines, unexpected events, stress, so just like regular stress, but also just that chronic stress or early, you know, trauma. Those are also triggers, can be triggers or contributors. Anxiety, fear, uncertainty. So some of these things you don't think about when you see angry outbursts. Well, maybe the kid's scared. Maybe they're anxious. Maybe they're feeling unsure, really feeling scared. And, you know, they don't know what's happening next. Anticipation of failure. This is one of the things that was mentioned in the survey that somebody wrote in. And I love that. I see that. That made me really think. It's not one I had thought about before, actually. And so it's like, I've learned from you. I think about some kids that I know, especially preschoolers, who become so aware of what's expected of them that sometimes they'll end up having a major tantrum in order to escape engaging in something that they know they're not good at, right? They really start to have that sense of shame. And somebody else mentioned shame. Discipline, you know, being disciplined or feeling shame when they're getting disciplined and then feeling shame. So these things that we think, what, that triggers outbursts, but it can. Interruption. So these are particularly with children on the spectrum, like interruption of repetitive or their kind of compulsive behaviors that they really feel that they need to engage in, or removal of preferred items, activities. These have been everything that attention seeking. Yeah, and that's sometimes what we think of often. Oh, he's having a tantrum. He just wants attention. Well, who doesn't want attention, right? So sometimes attention seeking tells us something like, okay, let's figure out how we can provide attention without them having to have a meltdown for it. Medication, so side effects of medication. I also want to note, I want to echo what Mary was saying, how helpful medication can be as well. So yes, some medication can increase irritability and can increase outbursts, but then there's other medication that can work beautifully in helping to kind of help the child regulate and manage those behaviors more. So I just want to mention that. And then hormonal changes in puberty. This is not something I deal with in my young children because they're not there yet, but yet people mention this as well. And we all know that. Those of us who've been through that know how irritable you can get. And then seizure activity, of course, can be a trigger. And I think that's it. Oh, and several people reported, and this is very common, especially also in my work with young children, not being able to identify the triggers, just not knowing, or just feeling like everything triggers an outburst. And so you feel like you're walking on eggshells all day long, trying to just keep, not to do anything that might trigger it. What's missing from this list is, and it's purposefully missing, is bad parenting or poor, right? These are not, it is not the result of, it is not one's fault. It is not a parent's fault when their child is struggling. Yes, of course, there's that very, very rare occurrence of a parent who's really struggling and is engaging in maybe some abusive behavior with their child that is a trigger for these outbursts. But the vast majority of time in all my 40 years of work, it's typically not that. It's not the parent's fault. It's nothing that they're doing wrong or, not enough of, or not enough of, or too much of. It's that their child is struggling with learning to regulate their emotions and behaviors. And as Carly was saying, there's not been a roadmap for this. There's not a good understanding of this. I feel like in the early childhood community, we're starting to get there little by little, really understanding, but for so long, it's been the parents have been blamed. Oh, you're not firm enough. You're not disciplining enough. You're too firm. It doesn't matter what a parent does. Whatever it does, it's somehow their fault for their child's behavior, for acting like this. And it's not. I think that Mary emphasized that very lovely and well. That's not on the list. Here's where the 8A and the 2A community really converge. I mean, it was very similar beforehand. But as Gabi mentioned, there's a lot more in common than there are differences, especially when it comes to these challenging behaviors. Most people have sought some professional help. Some people, a couple of the other responses were they talked to their pediatrician about it and told that there was nothing they can do, or they were given a book to read, or they were just nothing that they would talk to, but they were not given any, they just didn't know where to go for help. They were not given any guidance, or they were on such a long waiting list that they just gave up, or just was having a hard time, finding the help they needed. And these are some of the people some of the professions that they were seeking help from. And I was going to say, what were the others? Things like, well, palliative care, one person mentioned, OTs, occupational therapists were big. That was a big help. Some people said, behavioral analysts or specialists, that would probably be the ABA kind of category. Yeah, so different folks there. Oh, here's the other. I knew I wrote it down. There we go. They got medication, play therapy, palliative care, and occupational therapy were some of the other things. The good news is that that 29 of the respondents found what they were seeking somewhat helpful. Bad news is, well, 21, but only 21% 21 found it very helpful, and some found it not helpful whatsoever. And that's not good enough. We need to get better as the profession at this. And I think it was only after, and from what I've heard from the clinical trials readiness study and listening to some of the interviews, it wasn't easy to find support and help. And so maybe once they did, it was somewhat helpful, but I think it was a lot of work to get there. A lot of perseverance, persistence, kind of just patience. It was not easy. So here's where also the two communities converge, how it impacts the family life. They were saying that the challenging behaviors, many of them said that very much impacted their typical routines and ability to engage activities. Some of them somewhat, some not at all. And I don't know what the other is here. I apologize. I didn't have a chance to look at that. But to what extent does the behavior impact your sense of confidence as a parent and your own emotional well-being, which Mary, I think, spoke to very nicely as well. Minnie said very much so, right? Like, it's hard to feel confident as a parent when your child is having this major tantrum, especially in the middle of the grocery store, and you've got to like you said, in the concert, and they're pulling your hair, and you're having to pull them out. I remember when you were saying that, when my oldest had a huge fit in the library, and she was throwing books and and I just was like dragging her out of there, and I'm like yelling at her, and I realized she's a 2-year-old, right? But it's the same thing that we're like, and I felt horrible like after, because she just was, there was many reasons she is having that. There was a lot of good reasons for that fit she was having. It wasn't because she was a spoiled brat. She had, when I thought back later, I realized everything that had gone wrong that day. And why did we end up going to the library? That was stupid. That was not something we should have done at that moment. That was all on me, and she ended up losing it. And but it's a lot easier to drag a 2-year-old out of a location than it is a 22-year-old, right? So I understand. Yeah. So it does. It impacts your sense of confidence. And then the lastly, though, how confident are you in your ability to manage behaviors and the effects on family life? So even though you may not always feel very confident in the moment when you're dealing, but many folks said they're feeling somewhat confident in their ability to kind of to make, to manage the behaviors and sort of not have it completely impact their quality of life. So I think that's it. That's what I wanted to present. I'm going to stop sharing, share with all of you what you shared with us. So you can
Yeah, no,
see.
that's amazing, Erica. Thank you so much for summarizing what the families told us. And we're so grateful that you all took that survey. This is
Mhm.
really, and Leah and I talk every day. So we're always talking about how we're going to use this data. And we're really excited about thinking about this is helping us better understand what all of you are managing and trying to cope with at home, and how as a community we can start to do more to help you think about how to manage those. So thank you for summarizing that,
Oh,
Erica.
my pleasure. It was very interesting. It was very,
Yeah.
very interesting. Thank you.
Yeah, thanks for applying your many years of expertise there to help us to really see that. So, all right, I'm going to invite Jennifer up now to share a little bit about Jack's story.
Hi,
Hey there.
how are you?
Good. The floor is yours.
Excuse my appearance. I just got home from my son's school, so I rushed to get on as quickly as I could.
No, thanks for being with us. We all get it.
Okay, I'm glad because this is me today. So my son's name is Jack, and he is 5 years old. He will be 6 in October. He was diagnosed with SCN2A at around 3 months old. He was having a lot of cluster seizures since he was about 12 hours old. They finally, in a nutshell, got his seizures under control, and he stopped having them at about 4 months old. We found a neurologist in Orlando, Florida, that wanted to take him off his medication to see if Jack was still having seizures, and Jack has been off medication since about a year and a half old. We haven't had any breakthrough seizures or anything like that. The difficult task for us with Jack has been his behavior. It gets worse and worse, and it's to a point with Jack that we can't take him certain places, and we have to almost, as husband and wife, figure out who's going to take our other children, because we have 2 other kids, to places, even something as simple as a restaurant. If we're going out to eat with family, Jack just, unfortunately, he can't sit still. And then if you try with Jack to make him sit down or keep him from climbing on a table or getting under the table to elope from us, that's when the meltdowns happen. He will scream at the top of his lungs. And not much embarrasses us, you know. I mean, we're pretty much pros now at how Jack acts with screaming and stuff, but it's just really frustrating because we don't want to put other people, including our family, through the behavioral challenges that we're experiencing at home when they're out in public at a family gathering or a restaurant, or even something like a movie. We take our kids to the movies, and Jack loves the movies. He loves it. And there have been movies where he can sit still the whole movie and he does great. And then he starts screaming in the middle of the movie theater and everyone is staring at us, and one of us has to get up and leave with him. So it's really difficult, not only for my husband and I, but our kids too, because we have to tell them no a lot. And it really is kind of bad for them, because I don't like to go out without my husband with my son, because if Jack is going one way and then I have my other 2 kids, I can't keep my eyes on all of them at once, because I've got one that's nonverbal and he's eloping from me and trying to hurt himself or hurt somebody else. And then there's my other kids. So if my husband's working on the weekends, my kids are missing out on birthday parties. They're missing out on events, things that are going on in our community, school functions. So that's hard. That's the hard part of things. I took notes. I'm sorry. I'm just trying to, so I don't forget anything. Jack, some of his like triggers that we've noticed, and they do get better as he gets older, we've noticed. Jack was originally nonverbal. He could not communicate to us what his wants. So I noticed, and my husband noticed for a very long time, that a lot of his frustration was coming from him thinking he was telling us what he wanted. And we're like, what are you trying to say? What do you need? He could have wanted something as simple as a snack. And I'm like, oh, you want a cup? You want this? And it would become explosive with him because we weren't having that line of open communication with him. We were still learning, and he was trying to learn with us as well. But as like Jack is getting older, he's starting to pick up words here and there, and he's getting to the point where he can use very small sentences with us. Sometimes, it's not all the time. So that aspect of a trigger, we've noticed it has come down a little bit with the behavior. He's not as frustrated with us. He's not as destructive when he's trying to tell us what he wants, because Jack could get to a point sometimes where if he's not getting his way or getting what he wants right then, he'll throw things across the room. He'll tear things up. He'll hit whoever's near him, usually one of his siblings. And sometimes there's no calming him down. There's not. And then he'll just stop and he'll go back to doing what he was doing and act like nothing happened. And meanwhile, some of us have scratch marks and are red and being hit, and Jack's just totally fine. He's good to go now. And that's hard. That's hard on our kids, because Jack is 5 and my other son is 6 going on 7. So they're very close in age. And then my daughter is 9. So she tends to understand things a little bit more and can kind of pick up when Jack is getting frustrated. But my other son doesn't. Like, this afternoon when we got home, he wanted to play with something that belonged to Jack. Jack wasn't having it. So it was an emotional screaming match. And like my other son is staring at him like, I just want to play too. And I have to tell him, just leave him alone, put it down. And it's not fair. It's not fair. And I feel terrible for it. He destroys things. I know that the last lady that was speaking talked about like self-injury. Jack's, when he was younger, he would bang his head a lot, especially like in therapy. When we go in occupational therapy, If he got frustrated with the OT, he would lay on the floor and just start banging his head backwards. I don't want to say he's grown out of that, but he hasn't really done that a lot lately over the last couple years. But he will take his fingers out of frustration and put them in his mouth and bite them. Not to the point where he's drawing blood or anything, but you can tell he's harming himself, because afterwards he'll go ow, and you can see the teeth mark on him. So beyond the destruction and the biting of his fingers, it's the constant screaming. He doesn't get his way, and he will scream and scream at us. And to the point where I was outside one day and the neighbor said to me, "Oh, I heard your son screaming yesterday." And I'm like, "Yeah, you don't have to call the police. He's just a screamer. He likes to scream." And I don't give me a moment. I don't know how to stop it. And the doctors that we have here in Florida, they haven't been much help, except telling us, "Oh, we can refer you to ABA therapy." But Jack was not diagnosed with autism. He was just diagnosed with epilepsy and said to have delays with some of his cognition and his speech. So the places that can get Jack in, if we want to try ABA, will not take him without an actual autism diagnosis. And then the ones that said that they would take him are like a year and a half out on a wait list. And I'm like, so we have to sit here for a year and a half and not have any help, and we don't know what to do with him. Nobody in Florida wants to help us with him. And our pediatrician just basically told us, well, he's being a toddler. And I'm like, wow, that's weird, because my other kids didn't do this. And he does have his diagnosis, and our pediatrician doesn't want to help either. And I've asked if, I'm not one to start jumping with medications or anything like that, but I did speak to him about, does Jack need something to help calm him down? Is there something maybe that could help him? And the doctor basically told us, just change his diet. I'm like, to what? What do we change his diet to? He literally eats healthy. What am I supposed to do? Do I cut something out? And it's almost like we're just being ignored. Nobody wants to help us. So we basically live in our house like recluses, because we can't leave with him. We can't go anywhere with him. He runs from us. He got over our fence one day when we were outside playing with him. We had to jump over the fence after my son. Thankfully, he thought it was a game and was just running back and forth in our front yard. But um, he has no understanding of danger, and I don't know what to do with him anymore. I don't know. And my ultimate thing is to keep him safe, but at the same time, like, I have two other children, and I see sometimes their faces where they're like, they understand Jack, and they're amazing with him and being patient with him, but I don't know how to manage this with all three of them, because they're missing out on so much too. And I don't want to put Jack in situations that are unsafe for him or another person. My God, if he were to attack someone else's child, and I'm just like, "Oh, I'm sorry, he's got a disability, he's got a diagnosis," they're going to look at me like I'm insane, and it's not okay. So, um, that's where we're at with him.
Yeah.
Other triggers are, his toys. He doesn't want anybody touching his stuff. You touch any of like his Toy Story stuff, his favorite cups, anything, it's on. Like, he will literally just attack my other son. And, it's not all the time, but it's enough that, my son is getting to the point where he wants to defend himself too. And I'm just like, no, let me handle it, Alex. My other son's name is Alex. And, I don't know what to do. And, we live in a county where our special needs classrooms they're not that amazing with teachers. They're very understaffed. We have a really high turnover rate here in Flagler County. And we've had even some of like the best therapists in town tell us that from areas they've been in, the school system here is not that great with special needs kids. So I homeschool him now. He's about to go into kindergarten, and we kept him home because I'm terrified to send him to school. What if he gets out of school? What if he gets hurt? He can't tell me what's going on. What if he hurts another kid? And then you hear things in the news of, these kids being abused, and that terrifies me. So I'm a little bit all over the place.
Jennifer, thank you so much for sharing. I mean, you brought so many incredible things to light, and I think we're so excited that now we have Kelly who's going to respond and give some thoughts based on your story. So,
Okay.
Kelly, thanks for joining to kind of give some perspectives.
Yes, thank you. I'm very excited to be here. I'm just gonna give a very quick overview of my background, and then I'm going to do a really high level overview of what I do and how I would think about Jack from my professional perspective. So I'm a licensed psychologist and a board certified behavior analyst here in Iowa. And Jennifer actually voiced very well all of my frustrations with the field of ABA and its limitations to autism and autism specificity. And I just am in the fortunate position being a licensed psychologist that I can see anyone with challenging behavior and still do what a behavior analyst. I do everything a behavior analyst does related to challenging behavior, and I am not limited by that diagnosis. So I have a lot of frustrations that I'm happy to talk about on a totally different day about that. But I will say, so I am also, like everyone else on the panels talked about, new to SCN2A. I actually Leah came and talked in Iowa back in the fall, and I went and listened to her story and what the SCN2A Foundation does. And it just had me thinking, I wonder if these kids have challenging behavior. And so I went and talked to her after that, and she was like, oh yeah, we do. And it just like opened my heart of how can I be helpful? How can I offer support to the 2A and 8A communities for what I do? Because again, I know ABA in many places is very limited to an autism diagnosis, and I think that's frankly just ridiculous. So that's just very quickly. I also do a bunch of research. So we were one of the first groups, or probably the first group in behavior analysis to demonstrate the effects of telehealth for challenging behavior with the way we approach assessment and treatment of challenging behavior. And I focus a lot on treatment relapse. And so when thinking about, and this will, and we're getting like major storms here in Iowa, so forgive me if I look a little distracted. So treatment relapse, we look at, we get treatments in place, things are going well, right? And then when there's naturally occurring challenges to treatment, we tend to see challenging behavior come back really quickly. And so a lot of my research is focused on what do we need to do in treatment so we get persistence of treatment effects, even if treatment components are removed or not, grandma does something totally different than they're supposed to, things like that. So I'm going to share my screen really quick. I'm going to fly through some slides, and some I'm not going to really go over at all. Let's see, I'm not sure what you're seeing. Are you seeing the whole screen of the slide, not my notes?
Yep.
Okay, perfect. So let me just fly through. We don't need to go over, we already talked a lot about the various behaviors you all are seeing, and that is true. And Jennifer talked a lot about some of Jack's behaviors, throwing, hitting, crying, screaming, elopement, all of these kinds of things. We've also talked about how challenging behavior can be developmentally appropriate. And Erica did a nice job talking about, often we think of behavior as being considered some form of communication. It's how babies communicate that they need something. But I do want to note here that even though it might be developmentally appropriate, and the behaviors we're talking about today are not, I would consider them beyond what we would think is developmentally appropriate. But even if they are developmentally appropriate, doesn't mean we have to accept that. We don't have to accept that behavior is their form of communication, therefore we just let them hit their heads. there are behaviors like self-injury that are never going to be okay. And we think about that from the perspective of, we don't know what's happening in those little brains or their big brains. You know, how many times can you hit your head before you are doing damage to the brain? We don't know that information. And so I approach behavior, or behavior analysts will approach behavior from understanding, what are we trying to get out of? What are we trying to communicate? And then how do we replace those behaviors with something that's more appropriate, or maybe more desired, maybe more universally understood, and we work on that. So Matt's not really going to go over this fine line between developmental versus disordered. We kind of already talked about that a little bit. What I am going to talk a little bit more about is, from a behavior analyst perspective, we look at behavior, we are looking at behavior by function. So we're looking for behavioral function to guide and influence our intervention or treatment plans. So as Erica mentioned, we are the detectives. We are going in and getting all this information, and maybe we're manipulating the environment in different ways to understand what the behavior is trying to get at, what is the outcome that someone is looking for, so that we can match treatment to that. We don't look at challenging behavior from the perspective of, oh, there's a treatment for aggression, or there's a treatment for self-injury. We look at it from, it doesn't really matter what the topography is, whether it's severe tantrums. And I saw someone put in the chat, you know, do you still call it tantrums if it happens all day long? And that, I think, just, we can talk about that later. It doesn't really, again, doesn't matter what the behavior is, but what is the outcome that they're looking for? And so kind of looking at a 4-step process, but most of what I'm going to talk about here today is the step 2, thinking functionally, and then some step 3 of some ideas that we might begin to think about in more in relation to Jack's story. So we do know that challenging behavior, there's many causes for it. Sometimes it's one, sometimes it's a lot. And so we can think of temperament, right? If you're really stubborn, my kids are super stubborn. I'm stubborn. They totally get it from me. And so that can play a role. But neurobiology can have a role, right? In Jack's case, he has been diagnosed with epilepsy, and that absolutely can impact behaviors. Now, he's been seizure-free since age 1 and off his meds since over the last 1.5 years. So that's amazing. So maybe that's not an area I would particularly hone in on right now, because it's likely not contributing to the current displays of challenging behavior. We look at biology. You know, when I talked with Jennifer before a few weeks ago, she's like, well, when he's sick, he's really moody, right? And so we look at that definitely, or maybe he's constipated. And so we look at those biological factors. Some of them are easily treated, some are not. But making sure that we're accounting for those, and being able to discriminate between what's maybe more biologic that has something to do with internally what's going on, versus other things that are more environmental. So they're behaviors that are happening for social reasons. Erica talked about, you know, everybody likes attention, right? We have attention-seeking behaviors. Well, that's one of the environmental social variables we'll look for. Is behavior happening because I want mom's attention, or I want my thing when I want it, those kinds of things. So from my perspective, after we've kind of sifted through the biological things and, you know, are sending those referrals out on the medical side of things and making sure we've ruled those out, or we've ruled them in and we're taking care of them, I'm going to hone in on the environmental factors. So we tend to look at 4 main functions of behavior. So we look at escape. Am I trying to get out of doing something I don't want to do? I don't want to brush my teeth, right? I don't want to take the bath. I don't want to do that math worksheet. You know, and I'm going to give you very simplified versions of these. They can get a lot more complex. And someone like me would go and begin to look at that. You know, is the math too difficult? Is it too many problems? Are we making them do their work? There's so many variables that can impact that. And my role is to understand what all of those things are going to be if it's not just a simple, I don't want to pick up toys. Other functions we look at on the positive reinforcement side are, do I want attention from others? Or do I want what I want when I want it, right? We think of us toddlers are this way. And then we also, there's sensory components. So there's something internally reinforcing that's happening, irregardless of what's happening in the environment. And so we'll look for those things, and then we try to match treatment to that. So one way we do this is when I start with a family, I'm going to interview them. So I'm going to ask these triggers, these antecedents, and these consequences. So triggers, what's triggering that behavior? Consequence, what's maintaining that behavior? Why is that behavior continuing to happen now? Don't really worry so much about how it started in the first place. I worry about why it's continuing and what effect that's happening. So like when I talked with Jennifer the other day or a couple weeks ago, you know, if Jack is near his brother or his brother's trying to play with him, that triggers some of his behavior. And then from the consequence side of things, Jennifer talked about, she'll tell the brother to leave, right? Like, just leave him alone, like, don't worry about it. Or if Jack actually is engaging in the behavior with his brother will fight back, right? And so trying to understand, okay, well, so if Jack wants to be left alone and brother is told to leave Jack, Jack gets what he wants, right? So he gets out of having to interact with somebody he doesn't want to interact with in that moment. That's going to potentially reinforce that behavior. And so I'm going to look at that and be like, okay, how do we switch things around, or what kind of skills do we need to teach so that maybe that outcome can still happen, but now it's happening because I'm engaging in a more appropriate behavior, like leave me alone, or I point to a picture card if I don't have the words to say that, are the ways I'm going to kind of look at that. Let's see, quickly, just trying to rush through because I know we got a couple more. So once we identify function of behavior, we're going to match our intervention plan to that. So if it's an environmental function, and you want to get out of something, I'm going to make sure you get out of that thing you don't want to do, but you're going to get out of it because you've done something I've asked you to do. So if I said, if you don't want to pick up your toys and you're hitting and kicking because you don't want to pick up toys in a very simplified version, you will get out of picking up your toys, but you're going to pick up one first, and then I'm going to let you out. Or you're going to say, break, please, or you're going to communicate with me in some way that I don't want to do this right now, and then I will let you out. But otherwise, you're not going to get away with not doing it. It's just, again, very simplified way of looking at it. So lots of different antecedent strategies we might put in place to prevent behavior. And so giving warnings, you know, in Jack's case, when it's something he wants right now, but he can't have it. So maybe we need to work on some of this delays, tolerating delays to things. But also, can we put the item in a location where it's going to stay safe? So now we know, oh, yeah, it's always in your basket. And when you get up in the morning, it's going to be right in your basket. It's going to be where we left it, right? And begin having some of these things that might help put more structure in place. We're also going to work on strengthening the desired behaviors. My world, I focus a lot on communication. We call it functional communication training. And so we focus a lot on teaching that in whatever form that may be. AAC devices, sign language, vocalizations if we have them, touching picture cards, a variety of different ways. We want to reinforce those desired behaviors when they occur, and we want to not give the outcomes they're looking for when the challenging behavior happens, which often means giving some neutral responses or ignoring those behaviors. And again, this is all taking into account that we've taken care of the medical conditions and the other things that are going on. Or maybe we're doing something slightly different when we can understand that, oh, this is something that's being caused by GI pain rather than, oh, because I was cooking dinner at that time. And so for me, understanding those medical conditions or other psychosocial factors, we do want to identify and address those. Having caregivers highly involved, very, very important. You are the experts in your children, and having your understanding of what you think is going on can be really helpful. And then we do want to reduce the challenging behavior, we do want to replace it with something that's more appropriate. And so for me, my world, I'm identifying a function, I'm making environmental modifications, we're replacing those behaviors, we're reinforcing appropriate behaviors, and we're taking those inappropriate or challenging behaviors and we're largely not going to let them get the outcomes that they're looking for. And one thing I think, just to end here quickly, that I resonated with what Mary was saying earlier, that I just wanted, it reminded me of a quote my mentor always used to say, we control what's controllable and we don't let the rest do us in. And so I just think about that and how there are going to be things we cannot control. But if I can help with a slice of something we can control and we can identify why it's happening in those particular situations, then we can make inroads there, right? And then we can start dealing with some of the other things if it's, a target for you and important for you. But otherwise, we control what's controllable and then we move on. So I'm going to end there just to give other people time.
Oh, amazing. Thank you so much, Jennifer, for sharing. I think you had a lot of people who are nodding their heads and saying, and families who are saying, I've been there. And Kelly, thank you so much for honing in on it and helping tackle and give some advice and strategies there. I want to pass it over to Chris now, who's going to tell us about Maddie's experience and their story. And then we'll hear from Carly and Dr. Tate.
Hi there. And we were kind of chatting in the host chat just to set expectations that this is probably going to run over. I just want to make sure everybody's cool with that. I'm going to try to shorten mine because everyone has done such a great job sharing. The other two moms have really shared already a lot of what I was going to share. So we're all experiencing many of the same things. So I'm just going to focus on things that are a little bit different. So Carly can take over. Like she said, I am Chris Ray, and I live in Kansas City with my husband and my 17-year-old daughter, Maddie. Maddie has SCN2A related disorders, including autism, intellectual and developmental disabilities, and also, as Carly mentioned earlier, autonomic dysfunction, which for her results in a hyperactive fight or flight response. And we're finding that in many of our kids with SCN2A. Maddie has all of the behaviors on the survey, and like Jack, her default to everything is screaming. Doesn't matter what it is, whether she's frustrated, upset, uncomfortable, she's pretty much screaming most of the time. I will say, from having a girl, my experience has been that, and I think Laura mentioned this in chat, that her behaviors definitely did increase when puberty hit. And in fact, she went through early puberty. So things started a little bit early for her. I would say in about 4th grade, we really started to see an increase in her meltdowns, to where they were becoming more self-harm, and lots of injuries to herself, from slamming herself on the ground and hitting herself in the head. And then when we hit about age 12, things really got, from my perspective, to what felt like the point of no return. We added in impulsivity, manic behaviors, obsessive compulsive disorder. She was flying into rages, and started, if somebody was in her vicinity, she was going to hit them too, not intentionally, but just out of reaction. I will say, everybody's had really great suggestions so far. I don't have a lot to add as far as triggers, but I'm a data geek. It's come to my advantage. I want to get down to the root cause of things, just because I like to have solutions to my problems. And it's taken years to get there, to the point where I really have uncovered some of these things that were just shared. and figured out what works best for Maddie. One thing that worked really well for me was daily journaling. I get very OCD about that myself. I don't have a good app for that. I wish there was one. But I track her reactions, I track her activities, her bowel movements, her menstrual cycle, weather changes. And by doing all of that tediously, I have been able to identify her triggers. As we discovered through the survey, 9 times out of 10, those are probably pain related to some degree. And I found too that barometric pressure is a huge trigger. I track that now through AccuWeather, and I can see the forecast. And when I see that barometric pressure dipping, I can guarantee her behaviors are going to go through the roof. And I get headaches too, so that kind of clues me in as well. That's, just knowing what those triggers are is a huge help. Helps me be more proactive in the things I can control. If I know that's coming, I can dose her with Tylenol and head off the headaches. There's many times, like we've said, that things are just out of our control. We don't know when things are going to hit. The best thing I've learned is that when Maddie gets into that meltdown mode, I just try to reduce outside stimulation as much as possible. I'll try to get her to a quiet, dark place. I avoid talking as much as I can. I use visuals to communicate with her. We've created this, I don't know if you can see this body chart. No, you can't with my background. Like a body chart visual and a what do you need list, and she can read a little bit, so that helps. So when she gets like that, I'll present those to her and try to prompt her to tell me what hurts or what she needs. She's pretty in tune with her body. She just can't always effectively communicate it. And she'll often point to a body part, or she'll point to something like weighted blanket or Tylenol, or just leave me alone, which is often as a teenager, the response. So those have been helpful. If she doesn't answer, I just make a guess. Like if she's hitting her head and saying bonk, I'm like, probably a headache. Let's try Tylenol. Also, she has a lot of anxiety. We've discovered an amino acid called L-theanine. I don't know if anybody's tried that, but it's been great for her and for me. Works within about 10 to 15 minutes most of the time, gets her calm. School has called it a miracle with her. So I'm glad I discovered it. Maybe it might work for somebody else. We tried prescription meds, like many of the rest of you. We didn't have great luck with them. We had really horrible luck with SSRIs. We ended up in the ER. So I track meds too. That's, my data geek's kicking in there too. I track what med it is, when we started it, what the symptoms are, what the drug class is. So if some other doctor comes along later and says, we want to try this med, I go back and say, is that the same drug class as this? Oh, look what happened here. Maybe I shouldn't try that particular one. Let's try something else. So those are big things. The other thing I've done as far as documentation is I created a caregiver guide that includes her symptoms, her triggers, what works best for her. And I update that regularly. I share it with her entire team, her school, her therapists, people at church, people at camp, family members. It just helps keep everybody on the same page and be consistent in how we address her behaviors. It's also lessened the amount I have to advocate on her behalf. So that's reducing stress for me, giving me some peace of mind. And then, like everybody else has said, self-care, huge focus needs to be there. We sacrifice so much for our kids. We need to make those same sacrifices for ourselves. I'm at a point now where I'm trying to put the guilt aside, and I don't care what anybody thinks. I know how important this is. If I get to a point where I lose my patience, her behaviors are just going to escalate and make things worse. And my default has been to scream as well. And I don't say nice things when I'm screaming. So, if my husband's around, I don't ask. I tell him, I'm going to take a walk. You come in and help. You don't have an option. I leverage the Medicaid waiver a lot. We've got personal care assistance that's really helped with respite time. Just summarizing, giving myself that space has enabled me to step back and give Maddie more space. I don't try to fight every fight. I resist the urge to fix everything for her. Sometimes she just needs to work it out on her own. Sometimes I need to let her scream. Sometimes, that's the best way to process things when you don't have the mental capacity to really think through it. And when I'm having control over my reactions, her honestly, her meltdowns, her explosions have become much less frequent and shorter in duration. So I'd say out of all of the things I've done, that's probably the biggest one. I'm
Wow.
going to wrap it up.
Yeah, no, that's incredible. Thank you so much, Chris. You really hit on some new things there and shared some great strategies. And I love the data geek. That always helps us learn using data for decision making, right? That's a
Right.
critical tool. All right, I'm going to invite Carly and Jody on to give some response and some thought to what we heard here.
All right, so I'm just gonna share a PowerPoint. One second here.
And while the PowerPoint's coming up, I just want to note that, the idea of autonomic dysfunction or dysautonomias came up with Chris's story. And I put in the chat the webinar that Chris and had mentioned and Carly mentioned earlier that we actually did with Families SCN2A through our Deep Connections project a few years ago. And it's a lot of really terrific information about autonomic issues. So worth checking out.
All right, can everybody see my screen?
Yep.
Okay, awesome. So I'm gonna go talk about Maddie as an example of how we would evaluate and manage challenging behavior. So I'm gonna skip over the definition. We've talked about how there are multiple causes, and usually we need an interdisciplinary approach. So when we see people for the first time in our clinic, it's a combined visit with psychiatry and psychology. We're both in the room asking questions together and learning as much as we can. And then within our clinic, we talk also with family medicine provider and speech path to have a really comprehensive evaluation. And then we're always in communication with people's primary care providers and other people who are taking care of them outside of our clinic so that we're all on the same page. The first thing we do is try and learn as much as we can. And it is a lot of history to learn about, to understand all the different things that could be contributing. So these are all the things we talk about at that first visit, and it's pretty much everything you can think of that would be relevant. For Maddie, you guys already heard about her a bit. You know that she lives with mom and dad at home. She's 17 years old. She likes using her iPad, playing games. She also uses it for communication. She's a typical teen. When she's good, she's really good. And she knows a lot of words, and she also makes up her own words. And she has a loss of function mutation in SCN2A. Her behaviors started around the time of puberty, and Chris talked about what goes on with her. And Chris, like she said, is a robust data tracker. And so they were able to identify what the triggers are for Maddie. And that information is really important for us to know as well. So when we meet someone for the first time, the next thing we usually do is track data. I included a Hawkeye logo on all the things that I want to emphasize. So these are all the things we ask people to keep track of. And Chris mentioned a lot of these already. And another thing we really appreciate is videos, particularly for those episodes that where there are other symptoms like facial flushing or sweating or strange movements. It's really helpful to see the videos. Then the next steps are we consider all the possible underlying causes using a systematic approach. So we assume there are always multiple things going on. First thing we want to rule out is medical illness. The things that are most common that come up, we've already kind of touched on, and then more specific for your communities. You guys know more about all of these things than I do probably, but these are all the things that we would want to make sure that we talk about, that we're being adequately addressed. For Maddie, she has a lot of those things, and autonomic dysfunction is a big one. And then a few other things over there as well. And so to address these issues, we always communicate with the other providers who are managing those problems and let them know what the concerns are and whether there can be anything additional done to optimize treatment for those things. The next thing we think about is medication side effects. And as I go through this, I'm just gonna kind of breeze through the different categories that we think about. But I just want to preface it by saying a lot of these psychiatric medications we use to help with things that we think might be underlying the behavior. So anxiety, OCD type things, depression, all of that can contribute. And so these medications can be very effective. So I don't want to give the impression that we don't use them, because we definitely do, but they have side effects that we just need to be aware of. And so these are some of the things that we always ask about and monitor if we're starting medication or if they're on any medications that can cause these side effects, particularly if they're on multiple within the same class, then we just want to be aware of that, that there can be additive effects that make these symptoms worse. There are a couple specific things I want to mention for people with intellectual disability in general, and that's when we use benzodiazepines. So things like Xanax, Ativan, Klonopin, Valium. Those medications can have opposite effects in people with intellectual disability. So normally we would expect them to be calming, but sometimes they can cause agitation or disinhibition. They interfere with your ability to think clearly and make decisions. And so they can, in some cases, make impulsivity worse. The other thing I want to mention is specifically about SSRIs. In people who have autism, we've seen that more commonly they can have side effects of nervousness, agitation, and restlessness. And that is something that is not widely known. And so it's not to say that we don't use SSRIs in people with autism, but we will often start with a lower dose, go very, very slow, and we usually in general use lower doses than we would for people who do not have any intellectual disability or neurodevelopmental condition. And then you guys know more about side effects of seizure medications than I do, but that would be something more specific to think about as well. So Maddie has had several medication trials and has had side effects. And I just want you to notice that some of them caused worsening autonomic issues. So that's something that would be important to be aware of with medications. And then she has also had sensitivity to SSRIs, like I mentioned. So what do we do about medication side effects? So we review the entire list and consider which ones are essential or helpful versus which ones are not clearly helpful or needed or more likely to cause side effects or potentially interacting with other medications. And for those, we attempt to reduce and simplify. The next category we think about is psychiatric illness, and the prevalence is higher in people with intellectual disability compared to the general population, and the symptoms are more difficult to recognize. So when people can't communicate their mood, we often rely on observations about other things like sleep, whether they're doing activities that they used to really enjoy, and if that's changed, we pay attention to that. If they're less social, seeming more irritable or tearful, those can all be signs of depression. And I'm not going to go through all the symptoms for all the things we screen for, but I just want to illustrate that we do a really comprehensive review to try and figure out if any of these things are underlying the behaviors. For Maddie, Chris talked about anxiety and some of the behaviors that come with that. And this was a picture she sent me of the ripping at paper that has happened. So for treatment, we always start by optimizing non-pharmacologic strategies. And for Maddie, Chris has found some things that are helpful. And I just want to highlight again how she talked about allowing others to provide care was really something that was important. And then after that, we are always communicating closely with psychology to work on behavioral strategies. That's kind of the next thing we make sure that we're optimizing before we go to medication. If we are considering medication, we want to put our money down on what the diagnosis or problem is, even if we don't know what it is, which most of the time we don't know for sure. But we pick something and we decide to treat that with medication if appropriate. And then we evaluate whether it's helpful or not. And if not, then we stop that medication and try something else, or we might change our diagnosis. We always start at a low dose and increase in small increments. We wait at least a few weeks between changes. We only make one change at a time. So for example, if we stop a medication, we'll wait and monitor before we start a new one. We monitor for side effects the whole time, and if it's not effective, we then slowly go back down on the dose and then stop it. The whole time we're tracking data. And then another category is function, which Kelly talked about. So I'm gonna skip through that. And then she also talked about developmentally appropriate behavior. In our context, the thing that comes up a lot is usually self-talk, which can be totally normal. Most of the time is normal, but in some cases, people assume that that means that there are hallucinations happening. Most of the time, that is not what's going on. And then the other thing in the context of Maddie's story is that she's a teenager. So she, has some component of, dealing with life as a teenage girl. The next category is skill deficits. So things like limited communication skills. Maddie has some good skills. She uses a communication app and has some of her own words that she uses consistently to let mom and dad know that something's wrong. This is the chart that Chris attempted to show you on Zoom, where she can point to where she's having pain. And then other kinds of skills, things like social skills and knowing boundaries. And then just in general, going through life, we all experience new situations that require us to adapt. And so if we're lacking skills to do that, big life changes can be debilitating. So things like puberty, illness, death, and change in the support system can all be things that can contribute to a change in behavior. And so psychology are close friends for that. And we usually defer to them for recommendations there. And then finally, the last thing is behavioral phenotype. And what we mean by that is there a genetic diagnosis where certain types of behavior are more common? And so for Maddie, she has the loss of function mutation in SCN2A. And so this would be, an area where research is needed. If there are specific behaviors that are more common in folks with SCN2A or SCN8A diagnoses, those are things that we would want to find out more about. Because then when we're, working in the lab and working with like animal models, for example, we have some idea of what kinds of behaviors are the things that happen most commonly, and we can look for those in the models that we use to study potential treatments and study what's causing those types of behaviors. So to summarize for Maddie, we talked about a lot of different things that could be going on, and usually when we make a list like this, we then pick kind of our top 3 things that we think are the most likely or the most urgent to address. And that's where we start. And it's a longitudinal process that takes time and a lot of communication, and ultimately a lot of collaborating on deciding what to do next, because there's a lot of different directions that things could go. And very often we do end up trying a lot of different things before we reach a good amount of improvement. And so I just want to very quickly acknowledge that there are a lot of aspects of challenging behavior that are challenging for everyone. So for the individual attempting to communicate their needs, if they're experiencing physical illness or discomfort, for the caregivers, there are a lot of feelings that come with what's going on and a lot of worries. For clinicians, we don't have enough education on this topic. And a lot of times we don't have resources and we don't know where to send people. And then finally, the healthcare system overall poorly integrates care between specialties, doesn't have enough resources to meet the demand, and lacks adaptability for people with special needs when they come to clinic or come to the hospital. And so just to end on a positive note, the way that we're planning to address the challenges within our clinic is this model that we're bringing in within the next year, hopefully, where we meet regularly, our team with a group of caregivers anywhere in the state of Iowa, and we do this by telehealth. We're planning to meet every 2 to 4 weeks. And during each meeting, one person will present a case that they need help with or they want recommendations for. And then the team discusses, we exchange knowledge, and then that information can go back and serve the patients in the community. And so we're hoping that this is a way to expand care and spread knowledge that is really important and so hard to find. So the goal is to get best practices to everyone, no matter their circumstance, move knowledge, not patients. And this model was developed at the University of New Mexico and in the 90s to address people who could not access care for hepatitis C at that time. And since then has very much expanded and is all over the US, being used in different contexts for different conditions. And so I just wanted to end with sharing a quote from Yvonne Newbold, who gave a TED Talk. I'm gonna leave it there and let you guys read it so we can get to the discussion. But I just wanted to say it's a really hard position to be in as a caregiver. And so I think it's just really important what your communities are doing to have events like this to support each other and to learn. So thanks a lot for having me.
Amazing. Thank you so much, Carly. I think that was an incredible wealth of information. I'm going to have to go back and watch that again and probably again after that to try to capture everything you've got. But I think you have some beautiful visuals too that can help summarize for the families here. I recognize that we're over time. I am so appreciative of our panelists who are willing to stick around a little longer. And to all of you who are sticking with us, I know that this is a lot, but I think there's a lot of really incredible stuff happening here. And so I want to jump in and try to address some of the questions that came up through the chat. And thank you everyone for being active in the chat. It's really been fantastic watching your thoughts come in there. One thing that came in was, are there any studies that actually have tracked or show evidence of medications that could help behaviors? You know, families talk about lots of trial and error and challenges and not really knowing where to begin or manage, but is there any data to work with here or any evidence about medications for behaviors?
Do you want me to take that, Carly?
Please. Thanks, Dr. Tate. Yeah.
So my name is Jody Tate. I'm a psychiatrist here and the co-director of our program. There's not great data for medications. So really, when Carly was talking about what we want to do is try to figure out the underlying etiology. And I think Kelly had said, we don't treat the behavior, we treat the underlying etiology or the function of the behavior. So we really want to do a good job at doing that and at least develop a hypothesis, because again, oftentimes we don't know, but we want to at least develop a hypothesis based on the symptoms that we have. Now, there are times where the behavior is so severe and people are in danger, the individual is in danger, the risk of losing their placement, variety of reasons where we can't wait for all these things to take place. So then what do you do? So there's some very old data from this expert consensus guidelines that a whole bunch of psychiatrists that work with folks with intellectual disability did a survey on what medications would be used to treat a non-specific treatment of challenging behavior. And the first line is antipsychotics. The second line is mood stabilizers, like a lot of the seizure meds, like Depakote or lithium. That's not a seizure, Depakote or Tegretol or Lamictal, and then SSRIs. And you choose which med you choose kind of depends on, what you think, again, is the underlying etiology of the behavior. Now there's lots of articles out there that say, yeah, no. And so there's lots of strong opinions about antipsychotics. I'm a psychiatrist. I prescribe meds. I don't like meds. I try to get people off meds, but I do prescribe antipsychotics in situations where the behavior is very, very severe and it's a safety issue. And the folks that we see in our clinic have very severe behavior and have been through millions of meds, have had ABA, have had like, just can't get it under control. And the medication that we sometimes use is clozaril or clozapine, which is a big gun antipsychotic. But in those folks where nothing else is working, that seems to work quite well. And there is some data out there. So again, there's not great data, but there is some to support the use of antipsychotics, mood stabilizers, and SSRIs. But all the studies are kind of poorly done. Like, what are, what other symptoms do they have? So that's a very long answer to say, kind of.
Yeah, no, I think it's a really, I mean, it's important to understand the context for that too. And the research is not often done in our kids, right? So this is research done with people living with, maybe other kinds of conditions that don't necessarily have a background challenge like SCN2A or SCN8A. And that's one of the other questions that came up is, how can you tell what is related to the genetic disorder versus maybe some other mental health issues or behavioral challenges or what's age, we talked about what's age appropriate a bit, but is there a way to know, how much something like SCN2A or SCN8A is impacting these behaviors?
It's hard, some syndromes have a known behavioral phenotype. Now, it's my understanding there isn't like a specific known behavioral phenotype for the SCN2A or 8A. Sounds like there's some symptomology that people think is associated with it. But we often see people that have syndromes where we know that there is some challenging behavior associated with it. And again, there's no easy way. There's not like a blood test or a survey or anything to figure out, well, is this from the genetic syndrome? And is this from depression? Is this from, so it really is like a puzzle trying to figure out what's going on. And, the biggest thing is ruling out medication, constipation, and GI symptoms is like huge, huge, huge. So ruling that out. And then, that clinical interview of really kind of teasing out, is there depression contributing? Is there anxiety contributing? And if you think about it, like, let's say somebody has a genetic syndrome that isn't associated with intellectual disability or autism or challenging behavior, they can get mental illnesses too. So for a long time, it was thought that people with intellectual disability did not get mental illnesses, and so they were undertreated. And so it really is, there's no easy way. It is doing that big clinical interview and trying to figure out.
Mm-hmm. Yeah, and I think it puts a spotlight on the fact that this is something we need to study and we need to do the data tracking, right? Like, Chris is a methodical tracker, and people in the chat were asking, well, how do you track? And to me, what I've seen, it's like, well, you start looking at what's happening around things, right? And start to say, and then that's when you start to see potentially a pattern, right? And I think that for both 2A and 8A, and Leah, you can correct me if I'm wrong, we don't know, there's not research yet that shows that there's a phenotype that explicitly, has behaviors associated with it. But I think it's emerging as more and more people are getting diagnosed that there's probably something there. And it's probably something that we need to do some research into, which is great that we're talking with amazing folks like you who are already doing it. And so I think hopefully this is the beginning of the conversation. One other question that came up was around illness as a trigger. And I actually just had a conversation with somebody about this earlier today about the role of inflammation in illness and how that can potentially play a role in behaviors or challenges, and if there's something to do, if that the kid has challenging behaviors when they're sick, is there something you can do to head that off potentially if it is an inflammation issue, for example, or some other cause? Erica, I see you nodding your head. Do you have a thought on that?
Oh, Who were you asking?
I saw Erica nod her head, but go ahead, Jody, and then we can go to
I'm saying
Erica.
I don't know the answer to that.
Sorry, I didn't realize. I was just reading some of the things in the chat and I can't help but react. Sorry. No, I wasn't reacting specifically to that. So,
Yeah,
right.
yeah.
I got that.
Okay.
Yeah.
Yeah, I mean, I think it's, there's more questions than answers right now, probably.
Yeah.
One of the other things, and I see Alyssa just put this in the chat too, that came up was around supplements, and Chris mentioned, a natural supplement, I think it was, that's been helpful. Is there research around that, or, who do you talk to about that if families are interested in learning more about that?
There's again, I hate to always be a broken record, but there's not great folks to talk to about that are really knowledgeable. Most physicians are not. Sometimes functional medicine folks are, but kind of trying to get through the weeds of what is, people are just going to pee out if they have a whole bunch of supplements, or what is actually going to help. So there's just, that's another area where really more research is needed, because there's so much we don't know, so much. And oftentimes I think, there's something going on medically, we don't know what it is and we don't know how to treat it, but there's something here.
Yeah, absolutely. Yeah, and I think there's stuff in the chat going on about alternative medicine and alternative approaches. And I think, and Judy, you yourself, as someone who his job is to prescribe medicines, but try to avoid prescribing medicines. So I think, because we know our kids are often already on maybe 2, 3, 4, maybe even more, anti-seizure medications, not to mention medications to manage GI or ADHD or whatever. So, I think that there's a lot that we can still continue to learn. And I think that, we need to continue that conversation. And I'm trying to keep up with the chat too, because it's awesome what's happening in there, which is amazing. One mom actually put in something about for kids who elope, Project Lifesaver, and I think, which is a tracking. I think they wear a device that helps them be able to track people who elope. Mary, you're nodding your head. I don't know if there's any other things that Chris or Mary or the professionals, if you guys have any final thoughts about resources or, places that families can look into to find support or more information. I'm just going to kind of open the floor and let people have some final thoughts about. Yeah.
That's a great project if you have that in your area, where local law enforcement, if they offer it, can track somebody, a person with Alzheimer's or an autistic person that runs away, whatever the issue might be, and they have the ability to track them. So check out your local resources and see if that's available. It's definitely a plus if they have that. The other thing you can do is, if you have behaviors that one of the moms mentioned, don't call the police. I think we all have that fear when the kids are going off and they're screaming and things are bad. Megan is on our call here today, is a huge advocate of this, of reaching out to your local law enforcement and letting them know ahead of time, this is what we have in our house. I have a child with this going on, and you may get called, and this is how you should handle this, and this is what you can expect, and these are the things you shouldn't do. A lot of law enforcement is really in tune to that nowadays, and they're getting trained more in autism responses. So look into that. If your area doesn't have it, there's certainly trainings that are available that you can encourage them to do, and give them the heads up of, this is what's going on in our house. And they can actually enter your address right into the 911 system, and that will come up on the computers when your address is indicated.
Yeah, I think that's a great recommendation, and Megan is a big proponent of that. One of our SCN8A moms and ambassadors about, and she tells stories about how, her kid, she gets the police called on her all the time because they're trying to tackle her child so she doesn't run into the street, and people, are calling the police on them when the police know her daughter, and they know their situation. So when they come, they're not arresting them and taking them to Child Protective Services, right? I mean, it's sad that those are the kinds of things that families have to think about, but being very proactive, and I think continuing to talk with the other, it's clear from the chat and the moms who have joined us today that there is a wealth of information and experience and brilliant, minds who have been doing this and tracking and thinking and managing and adapting. So, I think these are conversations that we'll continue to have in our communities. And I'm really hoping that, we can continue the conversation with all of you, this amazing team out of Iowa, and Erica, who's at Northwestern. We're so incredibly grateful for your guidance and your research that you're doing, and helping our families think about what we can be doing additionally to manage, track, ask the right questions, advocate in these ways. So a huge thank you to Mary and Jennifer and Chris for sharing your experiences. You could tell that you are not alone. There were a lot of people who are giving a lot of, oh my gosh, that's us. Thank you for sharing. And just grateful for your advice and experiences that you've shared. And Kelly and Carly and Jody and Erica, really grateful for you taking the time and sharing your expertise here. We're really, this is really an emerging challenge in our communities, and we're really looking forward to continuing the conversation and trying to maybe actually get some more data, and be able to answer some of these questions more definitively. So, any final words from anyone else,
I
Leah?
just wanted to say
Yeah.
something.
Oh, please.
So I'm not an expert on SCN2A. I don't know if I have patients with that genetic syndrome, but I've been working with folks with intellectual disability and challenging behavior for over 20 years. And your kids, those of you who have kids, are so lucky to have you as parents, because I think one of the kids that have families, or I work with adults, but that have families that are involved and interested in learning, and there for their kid, and realizing, hey, I might have to leave the restaurant, and that's okay. I just will. My heart is just expanding, hearing all of your stories and the love that you have for your kids and the support. And so that's better than any medication or any treatment out there. So I just want to say that you guys have inspired me, and thank you.
Terrific. Well, thank you all so much. Thank you for pushing it to the 2-hour mark with us. I think we probably could have filled 4 hours, but we're going to call it at 2. And really grateful to all of you. Thank you so much.